Yep.
Yeah, all good. Okay. Hey guys, for those who don't know me, my name's Gavin. I'm just going to be doing the revision lectures on Neuropharm today. We'll basically be just going condition and then all the drugs that we treat it with. We'll try to keep it simple. We'll try to focus on what we need to learn, what's going to be core for the exam, and we'll try to keep it under an hour. Any questions, just put in the chat or like message me, and then probably Eddie can keep an eye on it and then let me know. But yeah, these slides look familiar because they're also on our PS Panda stuff. So check it out if you can't be bothered watching the lecture. All right, let's get started. So we'll start off with epilepsy and seizures. So what is a seizure? It's everything that you imagine it is. It's an abnormal, excessive, synchronous excitation of a population of cortical neurons. Important words there are that it's a bunch of different neurons. So you're going to get a lot of neuronal stimulation. And it's something that we don't like. It's abnormal, it's excessive, it's out of the ordinary. Two other features of seizures and epilepsy that we need to know about: you can get preceding sensory motor auras. So you get sensory symptoms like anesthesia, paresthesia, changes in your smell, vision, hearing, and you get your post-ictal amnesia. So after the fact, you forget what happened. You didn't realize what happened. And then these are the major causes. The probably biggest one that they might ask you about is alcohol withdrawal. So if people are really heavy drinkers and they suddenly stop, they might start getting seizures. Mechanism is pretty unknown, but it's thought to be metabolic. Other metabolic things that you should probably know about: hypoglycemia, hyponatremia, so low sodium, low calcium can all cause these seizures, as well as brain pathologies as well. How do we diagnose it? We're going to do some brain CTs, we're going to do some blood tests, we're going to do a urine drug screen. Epilepsy is pretty different. It's more than one seizure basically, and they're usually unprovoked. So seizures only one time, epilepsy is two or more. It's kind of common, 0.5 to 1%, 1 in 100 people are going to have seizures or epilepsy. The actual etiology is mainly unknown, but it could be due to a variety of things. So any pathology that's just going to create scar tissue in the brain, and that's just going to cause pathological changes in the brain. But we don't really know the actual mechanism about it. And even if we did, it's not that important. So keep moving. How we diagnose it, we use EEG. So they put all those kind of wires and stuff onto the brain, measuring all the neural conduction and where the neural waves are going towards and stuff, and they can graph that. And it's characterized by epileptiform waves, hence the name epilepsy. In order to actually see that it's epileptiform waves, they have to be mid-seizure. So kind of makes sense. You kind of have to be having a seizure for you to be able to realize that they have epilepsy. But they can also happen in between seizures as well. And so having a normal EEG when someone's doing the EEG test doesn't actually rule out epilepsy. So that's important to know, which means we've got to use like clinical diagnosis, history exam, all those kinds of things to also tell us that people have epilepsy. How are we going to treat it? We can have them on medication. So we put them in anti-epileptics or anticonvulsants. Same thing, same name for same thing. We can do surgery to like ablate parts of the brain that we think are working too hard, doing too many things, or we can have them on a ketogenic diet, which is like scientifically, I'm actually know the mechanism behind it, but that's really common as well. So you probably know those things. So we'll think about what types of seizures we have. There's three big sort of categories we can put them in. We've got partial, we've got generalized, and we've got status epilepticus. So we'll start with partial. So partial is where all those abnormal neurons that were firing that I was talking about, they're going to start in one place of the brain, and they're only going to stay in that one place of the brain. They're not going to go anywhere else. And we can classify them into simple or complex. So if it's simple, they're going to remain conscious. If it's complex, they're going to have impaired consciousness. And we can have all those symptoms that I was talking about before. So we can have those motor signs, sensory signs, but also autonomic symptoms. So people might lose bladder control, fecal control. People might dilate, things like that. And it can also vary with complex partial seizures. So the big points on this slide is what they are and how to differentiate simple and complex partial seizures. Then we have generalized seizures. So as opposed to them being localized to one part of the brain and partial seizures, we have generalized seizures which are involving the whole brain. And we're definitely going to be losing loss of consciousness here. In tonic-clonic, that's what our stereotypical seizures are going to be looking like. So people are spasming, their arms are like flailing around. and they're yelling and like frothing and things like that. Or we can have petit mal or absent seizures. These are more common in children, and instead of flailing around, instead of jerking around their body and stuff, they're just looking straight forward. They just stand still and stare into the distance kind of thing. But there's no real motor signs that we can see. There's also these other ones that we have, but they're not that important for you to know about. Seizures can also happen in children as well. They have different names for those. Tonic-clonic is also called grand mal. So if you see grand mal, it's just tonic-clonic. All right, status epilepticus. So this is the last type. This is when we have either a seizure that's lasting a really long time, so more than 5 minutes, or if we have multiple seizures that are so close together that basically seem like they're almost one seizure. So there's no remission almost. Usually it's the tonic-clonic seizures that are going to turn into the status epilepticus. And it's usually because either people haven't been taking their anti-epileptic drugs, or they don't have enough, their dosage isn't high enough basically. And how we treat that is we give IV or rectal benzodiazepines. And we'll talk about this a bit later, what benzodiazepines are. And this is a medical emergency as well. Cool. All right, what do we happen after seizures? So we get that confusion that I was talking about. They don't remember what's going on, or they're just a little bit in a daze, or we get paresis, which we call Todd's paralysis. And that's because it's almost like ongoing hyperpolarization of the brain that lasts a bit longer than it's meant to. And so we get like hemiparesis or like paresis of arms and legs, things like that. But that's just a name that you should know about, a thing you should know about. All right, so what's the neurochemistry? What's the pathophys going on? Like I said before, it's too much abnormal neuronal excitation. So either we've got too little inhibition or we've got too much actual excitation. So it's going to be one or the other that's going to be causing these seizures and epilepsy. Inhibition is caused by our GABA neurons. Those are the ones that are going to inhibit things in our brain by opening our chloride channels. And excitation is going to be stimulated by glutamate and NMDA receptors in particular through calcium and sodium channels. So we've got too much glutamate going on, then we're going to have too much excitation, which is bad. We've got not enough GABA, we're going to have not enough inhibition, which is also bad. So we basically use our anti-epileptics to counteract this. So we've got too little inhibition, we're going to enhance our inhibition. We're going to increase the amount of inhibition going on. If we've got too much excitation, then we're going to inhibit the amount of excitation going on. And that's how our drugs are working. That's how we like to think about them, and that's how I'm going to categorize them as we talk about them. So we're either going to inhibit glutamate transmission through sodium or calcium, or we're going to enhance GABA transmission through a bunch of these drugs. All right, so we'll talk about them one by one. So we'll start off with the ones increasing or decreasing glutamate transmission. So we'll start with carbamazepine. This is one of the most common ones, most commonly used in partial seizures. So indications are really important in seizures. That's the thing they can really test you on. So it's good to know that. There's just a few indications that you really specifically need to know. So how is this going to work? It's going to inhibit our glutamate transition by blocking our voltage-dependent sodium channels. So we're going to be blocking our channels. We're going to be blocking depolarization. And this is going to preference our high frequency neurons, so the ones that are firing more frequently, which is the ones that are implicated in seizures and epilepsy. And that's pretty much all you need to know about the mechanism of action. There's a bunch of different side effects, but the main one I would say to focus on is probably drowsiness. Because if you imagine you're inhibiting a bunch of your neurons, basically, you're just going to have lower amounts of stimulation in your body in general, and you're just going to feel drowsy. So that's probably the big one to know there. The rest are kind of just, if you have time, if you want to learn more stuff. All right, then we have phenytoin. So exact same mechanism of action that I was talking about before. But the important thing here is it's got zero order kinetics when we are trying to dose it. So that means the actual enzymes that are digesting phenytoin, they're not going to increase proportionally to the amount of phenytoin in our body, which means it's more likely that we're going to get phenytoin toxicity. So that makes it really, really hard to dose, which makes it much more toxic than carbamazepine. So adverse effects that you need to know, again, drowsiness, slowed mentation is common, but the big one that they really, really like to test is gum hyperplasia or gingival hypertrophy, whatever they call it. But that's something really, really important to know, as well as this zero order kinetics thing. They've both come up as exam questions, so be on top of that. Cool. Ethosuximide. So this is going to be doing almost the same thing, but instead of blocking our sodium channels, we're going to be blocking our calcium channels instead. And this is these T-type calcium channels are mainly associated with absence seizures. That's why we use it in absence seizures mainly. And we get a whole bunch of different side effects. Again, this is a common exam question. What is the most commonly used drug in absence seizures? Answer is ethosuximide. Yeah, cool. Valproate. So this is moving on to the ones that are increasing the amount of inhibition that we've got going on, increasing the amount of GABA. So what's valproate going to do? It's going to inhibit GABA transaminase, and that's the enzyme which metabolizes GABA in the presynaptic neuron. So if we're blocking the metabolization of GABA, that means that we've got increased amounts of GABA, whether it be neuronal or extraneuronal, so in the synapse. And so we're going to have more inhibition at the neural synapse. It also has a secondary function of blocking sodium channels, but that's not as significant as this first one that we're talking about. So really focus on this one when we're thinking of valproate. Important things here are more of the metabolic effects, so weight gain and increased appetite, as well as hair loss and alopecia. Cool. This is also a very commonly used drug. Diazepam, pretty much the exact same as valproate, but it's not on your core list. I thought I'd just include it because Richard put it in his lectures. But yeah, pretty much the exact same thing. Clonazepam. So this is a benzodiazepine. So this is going to be doing a similar kind of thing with GABA, but not exactly the same. So instead of increasing the actual amount of GABA we have at the synapse, it's going to increase the strength of GABA, the permeability at the actual at the postsynaptic neuron. And how it's going to do that? It's going to increase our chloride permeability. So it means the cell is more hyperpolarized, and it's less likely that a neural transmission is going to actually cross over into that next neuron. So instead of increasing the amount of GABA, it's just strengthening the effect of each GABA molecule kind of. And we use this when things are really bad, when we've got status epilepticus or refractory epilepsy mainly. So that's when they're not responding to any other treatments. Again, we get a whole host of different side effects, but probably the main ones are probably sedation, behavioral changes, and respiratory depression if it goes on for too long, because it can affect any other neurons in your body as well. Cool. Phenobarbital. So again, same sort of thing going on as clonazepam. So I won't focus on that either. But again, not core, so I wouldn't focus on it too much. This is a summary of the side effects. So as you can see, drowsiness is pretty much across the board over all of these drugs. We've got weight gain in the one starting with V, so weight gain, I don't know, however you want to remember it. Yeah, and then phenytoin has probably got the other things that you need to know about. So it's got that zero order kinetics and that gingival hyperplasia, so gum hypertrophy that we were talking about before. If you don't know, just go for drowsiness pretty much in general. Cool. This is a table highlighting what we're going to be using for certain types. So you can see valproate's used pretty commonly. Vigabatrin we haven't talked about, but it's used in these other types of seizures. You don't need to know. Absence seizures, ethosuximide is usually the first choice, or valproate, and carbamazepine in partial seizures particularly. And that's seizures. Any questions? No? Okay, moving on to Parkinson's disease. So what is Parkinson's disease? I'm sure you've talked about it today. We've got a chronic neurological disorder, and it's characterized by these motor symptoms. So we've got a tremor, we've got rigidity, we've got less movement, and we've got postural instability. Chronic onset, usually asymmetrical, very common in old people. Mechanisms are unknown, and it's idiopathic, which is good because you don't need to learn it as much. But the actual pathophys is characterized by this loss of neurons in the substantia nigra. And that's going to lead to a decreased amount of dopamine in that striatum, in that basal ganglia pathway, which means people aren't going to be having as much motor stimulation. And we're starting to get these symptoms of everything kind of just reducing in general. It's important to notice that we don't really get symptoms until we hit that loss of 80% of dopaminergic neurons. And that's when we start to decompensate pretty much. Yeah. How does it work? These are the pathways. I'm not going to focus on it too much because I'm assume it would have been talked about in previous lectures, but it's basically just a loss of dopaminergic neurons in your pars compactor of the substantia nigra. And that's going to lead to all these different symptoms in here. And that's kind of just in words there. Pathology, so actual histopathology is characterized by alpha-synuclein buildup, and they form into these things we call Lewy bodies. And you can really see these when people are on the autopsy bed and you cut up in their brain, but it's hard to diagnose that because we don't want to cut up people's brain while they're alive. So this is just a buzzword to know about. And this will help you in the future as well, like year 3, 4, 5, etc. Yep, cool. These are some of the symptoms. So we've talked about these 4 already. That pill rolling tremor, rigidity, less movement, postural instability, smaller writing, shuffling gait, mask-like faces, or less facial expression, pretty much, hypermimia, hyperphonia, quieter voice, and then you get like cognitive kind of problems, as well as that's like depression, things like that, which is also bad. How we're going to manage it, we're going to use mainly our medications, but if none of these are going to work, we're going to have surgical management as well. But this is much more uncommon because we don't like doing surgical things, and they're not as proven to work, and they're quite invasive, which is also not good. So we'll talk about each one of these as we go down, and we'll start off with our first line treatment, which pretty much everyone with Parkinson's will get, levodopa or carbidopa. Levodopa and carbidopa, sorry. So what is it? So levodopa is a metabolic precursor of dopamine, which can cross the blood-brain barrier. Dopamine can't cross the blood-brain barrier, so that's why we have to give levodopa. So it can cross the blood-brain barrier, and then it will be converted into dopamine once it's crossed the blood-brain barrier by dopa decarboxylase within the nigrostriatal system. And then we're going to get more dopamine, which is going to sort of reverse the effects of Parkinson's a little bit. This enzyme is pretty important. It comes up a lot. So I think it's good to know. Adverse effects that we need, which are very, very important. So dyskinesia, so we get too much movement if we have too much dopamine. So almost if we've got too much levodopa, that's going to cause that side effect. We can get nausea and vomiting if dopamine is being activated in our stomach. We can get end of dose deterioration. So towards the end of their actual medication that they're taking, the effects of levodopa are going to wear off. You get hypertension, hallucinations, and increasing tolerance over time. So people need to take more and more levodopa as time goes on, as they keep taking levodopa. So these are some clinical notes to know that they also test you on. Half-life is 2 hours. Remember that number. Levodopa, only 1% of it is going to enter the brain, and 99% of it is going to be metabolized by peripheral DDC. So we don't only have DDC in our brain, but we have it also in all the other parts of our body. And so we have to co-administer it with carbidopa, which is a peripheral DDC inhibitor. And it's going to make sure most of our levodopa, at least, is going to be going into the brain as opposed to be digested in the rest of the blood system. Decreased storage capacity for DA derived from levodopa. Can't really remember what I meant when I was writing that, but basically, when you give them levodopa, they're more likely to fluctuate based on changes in receptor sensitivity. So people can have really up and down days where they get like dyskinesia sometimes, and sometimes they're going to have like no symptom relief at all. Yeah, cool. Next, pramipexole. So this is like a second line agent. This is a direct dopamine agonist. So it's going to directly activate those dopamine receptors in our basal ganglia. There's some more advantages compared to other drugs like levodopa and stuff. We don't have to think about all that metabolization stuff. It's got increased reliability in dosing effects. It's got a longer half-life, so it's going to last longer. It's easier to achieve steady states, and it's less likely to have side effects. The main issue with it is it's going to activate our dopamine receptors in the peripheries and cause nausea, vomiting, and hypotension, which are pretty big. So we can treat it with domperidone, which is a peripheral D2 antagonist, to kind of counteract that D2 agonist in general. Other dopamine agonists that we need to know about are apomorphine and bromocriptine. Apomorphine, highly metagenic. Bromocriptine is going to cause things like gambling, impulse control disorders. So people have problems with that kind of stuff. Selegiline, irreversible inhibitor of MAO-B. MAO-B is going to break down a dopamine. So if we're going to inhibit that, we're going to increase the amount of dopamine at the synapse. Similar sort of side effects, we get nausea, vomiting, dyskinesia, orthostatic hypertension, and some brain side effects as well. Not that important, the rest of them. This is moving on to our third line drugs as well. Then we've got entecapone. So this is inhibiting CoMT. So this is going to mainly be used with levodopa. So it's going to slow the breakdown of levodopa pretty much and prolong its action and half-life. Again, similar sort of adverse effect with nausea, vomiting, dyskinesias, and brain stuff. Cool. Amantadine, we don't really know how it works, but it's just going to increase our dopamine and block reuptake. You get a bunch of different side effects. Probably the most important one, sorry, that's meant to say libido reticularis. It's basically like a skin rash that you get. Yep. Benzotropine. So this is an anticholinergic. Why are we using an anticholinergic in Parkinson's disease? Good question. So dopamine inhibits cholinergic activity in general. So if we have less dopamine, we're going to have lots of cholinergic activity, and that's also going to contribute to some of our symptoms in Parkinson's disease. So in order to counteract that, we use a centrally acting anticholinergic, which is benzotropine, and this is going to provide some symptomatic relief. And we get our normal adverse effects such as our muscarinic sludge, so our dry mouth, our constipation, urinary retention, and blurred vision in general. This is a picture highlighting everything that, summarizing it all in one go, but it's pretty much everything I've just said in a picture format. All right, Huntington's disease. So this is pretty much just the opposite of Parkinson's. You get too much movement as your disorder. Instead of it being a acquired disorder mainly, this is mainly an autosomal dominant disorder, and it's characterized by chorea, so mad movements, jerky movements, as well as cognitive defects and psychiatric symptoms. This is the genetics behind it. So we get increase in the CAG repeats in our DNA, and that's directly correlating with the amount of pathology and the severity of the pathology that we're going to have. It's going to lead to a loss of GABA neurons, and that's going to have less inhibitory effect, more excitation, dopamine hyperactivity, and then hence motor hyperactivity. Not important. Management, nothing really works against it because it's genetic. It's just going to continue. You can give symptomatic relief, but it doesn't really work. People die very young because of it. So it's a pretty bad disease to have. All right, moving on. Anxiety. So this is a normal motion people have, yada, 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 unsettling feeling of uncertainty and apprehension. More common in females, young people in 20s, and people with a family history of it. Common symptoms, you can just imagine a panic attack pretty much. So they get really fast heart rate, sweating, nauseous, sleep disturbances, things like that. Pathophysiology. What's the pathophysiology behind it? So it's basically, again, overstimulation of the brain, which is going to lead to a disruption of our normal activities. And that's mainly because of GABAergic hyperfunction. So too little inhibition of our brain's neurons. How are we going to treat it? We can use some conservative management, counseling, psychotherapy, things like that. Or we can use pharmacological treatment. So the main one we need to know about are benzodiazepines. Antidepressants can also sometimes be used as well in anxiety. So we got diazepam, which is a benzodiazepine. Like the benzodiazepines we were talking about before, this is also going to increase, enhance the activation of GABA by increasing our chloride permeability at the postsynaptic neuron. So it's going to make it less likely for a neuronal stimulation to happen across that synapse. And these are the clinical effects it's going to have. It's going to reduce our anxiety. It's going to also have effects on our sleep. So it can produce sedation and induce our sleep. And it can also reduce our muscle tone as well. So not only are benzodiazepines used for anxiety, they can also be used for people who have things like insomnia, et cetera, sleep disorders where they have trouble getting to sleep or staying asleep. Adverse effects. So if we have too much sleepiness, almost we can get drowsy during the day. We can get confusion and ataxia. And this is more common if we're putting them on a longer duration of benzodiazepines, or if we put in higher dose of benzodiazepines. You can also get anti-retrograde amnesia, so you can't form new memories, and you can also build up tolerance and dependency eventually. So that's why it's really important to wean them off eventually. Sedatives and hypnotics. So what are sedatives in general? So they basically exist on a scale from anxiety to anxiety prophylaxis to sedation. If you use stronger anxiolytics, you eventually just produce sedation. And that's basically a result of the side effects that we're getting, that drowsiness, adverse effect of our anti-anxiety drugs. If we want to treat anxiety, we're going to pick a drug which has a longer half-life, which is going to last longer, but it's basically going to be weaker because it's lasting longer. And then if we're picking a drug that we want to be really, really strong, we want to produce that sedation, we're going to pick one with a short half-life. Mainly, these are going to be used for things like maybe surgeries, where we don't want them asleep for too long, but we want them like dead asleep if we want them, want to be doing something on them. So these drugs exist on that spectrum, which kind of makes sense. All right, and then hypnotics. So what is the difference between sedatives and hypnotics? So sedatives, again, are going to have that sleepy anxiety effect, calming, sedative kind of thing. But when we have hypnotics, that's going to actually change our mental function in general. Ooh, whoops. So it's basically, again, existing on that low dose to high dose spectrum. If you're going to have low dose anxiolytics, you're going to have sedatives. If you're going to have high dose, you're going to have hypnotics. These are really common. And if you can go further, you can go further than hypnotics, and you can go to general anesthesia, where they're like pretty much stop breathing almost. And eventually that will lead to death and CNS suppression because they're not breathing properly at all. All right. So what is general anesthesia? So the main aims of it is produce hypnosis, so that drowsiness, that unconscious state, analgesia, and muscle relaxation. But not all of these anesthetics are going to do that. They can only usually do some of them. Only very few anesthetics can do all of those, that whole triad of things. So there's a few different stages of anesthesia that you need to know about. So we've got our induction. So that's when we're giving them the anesthesia, they're starting to take it in, and they're getting analgesia. They're getting that depression of their pain receptors initially, but they haven't got amnesia. They still are aware of what's going on. After that, they're starting to get amnesia. They're starting to not understand what's going on pretty much. They're starting to get irregular respiration. And that is what we call our excitement phase. Then we have our maintenance phase, or when we have surgical anesthesia. So it's when they're starting to operate. We've got regular respiration, but we've got a slow pulse and a loss of our reflexes. And then depending on whether you stop your anesthetic or you continue anesthetic, if you continue it, you're going to get medullary paralysis. So your medulla is not going to work, and that's where our cardiorespiratory centers are. So you can stop breathing, or you can stop the anesthetic at that point and they'll start to recover after that. Some of the important features that we want in an anesthetic is rapid induction. So we want it to start working very quickly. We want to have a wide therapeutic window. So we want to have as much kind of leeway before we get toxic effects from subtherapeutic doses or super therapeutic doses. And we want to have as little side effects as possible. So there's two types of anesthesia that we need to talk about. So there's IV anesthesia, so through the blood, through our veins. And then there's our inhaled anesthesia. So IV anesthesia. So some features that we need to know about. It's very quick induction because it's going immediately into the blood. But because it's good for short anesthesia and induction, it's not good for long-term anesthesia. It doesn't last very long, and it's lipid soluble. These are the drugs that we'll be talking about. Yeah. All right, so thiopentone. This is probably new content. I just realized, actually, I forgot that you haven't done sedatives yet. But again, this is having the similar effect on GABA. It's going to increase the amount of inhibition, potentiating GABA effects at the neuron. And instead of being actually metabolized, that's not how it's going to get rid of, the body's going to get rid of it. It's going to be actually redistributed to other parts of the body. So as its concentration decreases in the blood, you can see that's increasing in the brain, increasing in muscle tissue, and increasing in fat. And so that's going to be the cause of its short duration of activation of action rather than it actually being metabolized by certain enzymes or whatnot. Then we've got propofol. We don't really know how it works, but it's thought to have a similar mechanism of action. Again, it's got that quick induction, a little slower than our thiopentone, but it's useful for short surgeries. It's got a little bit of induction and a little bit of maintenance because it's a little bit slower in its induction phase. Side effects you don't really need to know about. Ketamine, so again, it's got a little bit longer induction. It's not as fast as the other ones, but it's got a little bit longer duration of action. And it's going to work at different receptors. So instead of working with our GABA, it's going to work with our glutamate. So it's going to be an antagonist at our NMDA receptors and block glutamate excitation. So we're going to block excitation at the postsynaptic action potential and prevent that. It's also got effects on muscarinic and opioid receptors. And so that's why it's useful for painful procedures, because it's also got that analgesic function kind of inbuilt into it. It's very good at that. It's got a whole bunch of different side effects, which honestly aren't worth remembering that much. I would focus on probably the last two. So your lower urinary tract symptoms. So people get problems peeing, basically. They have blood, they have pain, they have increased frequency, or they can get hallucinations, which is really common after using Ket when they're recovering. Then we've got midazolam. So this is also another benzo, again, doing that similar thing of potentiating GABA at the postsynaptic neuron by increasing that. Major side effects, CVS and respiratory depression, if you're taking other things that are also going to be acting on the similar receptors, because it builds up and just becomes toxic. And the other one is tolerance. So people build up a tolerance over time. All right, this is a table highlighting everything I kind of just said. Sorry for the poor quality, but I think it's a good table. Yeah, probably just look at it in your own time. Okay, so this is inhaled anesthetics as opposed to our IV anesthetics. And they're going to work in a bit of a different mechanism. We don't really know for sure, but we think it's because they activate these TREC channels, and that's going to cause potassium efflux, which means our actual neurons are going to be less, there's going to be less positive charge in our neurons, so they're going to be hyperpolarized. They're going to be less likely to be firing because they're going to be much lower below that threshold. Generally, they're very lipid soluble and very chemically inert, and their potency is related to their lipid solubility, which is really important. So how do we measure their potency? We measure it through their minimum alveolar anesthetic concentration. That's the amount of actual anesthetic which results in immobility where in 50% of patients when they're exposed to a noxious stimuli. So if our concentration to achieve that is lower, that means the actual drug is going to be higher. The potency of the drug is actually going to be higher if the concentration to achieve this is lower. And again, our recovery is going to be achieved through that redistribution rather than metabolism by certain enzymes. Cool. All right, so another important measure when we're talking about inhaled anesthetics is our blood gas partition coefficient, which is also a confusing concept. And I guess it'll probably make sense more when you're doing your lecture. But if you can try and understand it now, that'd be great. Basically, it refers to the ability of an anesthetic drug to diffuse across the lungs into the blood. And it represents basically the amount of drug that's in your blood. So I think that's probably the easiest way to think about it. So if you've got a higher coefficient, you've got a higher amount of drug in your blood, it's going to be more hydrophilic. And so it's not going to be moving into the brain as quickly. It's not going to be going across that blood-brain barrier. And so it's going to have a slower induction. It's going to work slower on the brain. If we have a lower coefficient, there's going to be a lower amount in the blood, which means it's more lipophilic, less is staying in that blood. And so it's going to be moving more quickly across that blood-brain barrier because it's more lipophilic. And that, our main one is nitrous oxide. And yeah, that just says the same things that I was talking about. So if it's more lipid soluble, it's going to be more likely to move across the blood-brain barrier. And so I've got this table that Richard likes to talk about. And I'll probably explain it better than me, but you've got blood gas coefficient. So if it's got a less solubility in the blood, it's going to move faster across the blood-brain barrier and it's going to have a faster induction. And that solubility is correlated with its potency. This is an unknown kind of mechanism, but it's just correlated. So if you have less solubility, it's less potent. And if we look down the bottom of the table, if you've got high solubility, if you've got more drug in your blood, it's not going to move as quickly into your brain, so it's going to work slower, but it's going to be higher potency. So our main one is methoxyfluorine here. These are some side effects. I don't remember this, didn't really matter, but just like breathing problems as well as hypoxia. So if you're mixing stuff with your oxygen, you're going to have less oxygen actually being breathed in every breath, and so you're going to get hypoxia. All right, depression. So depression, I'm sure we're all familiar with it, but you've got this cluster of symptoms, and you can classify it on a certain spectrum, very prevalent. More common in females, people with a family history, and young people, as well as all the things that make us have bad mental health, like divorce, pregnancy, social isolation, all that kind of stuff. Kind of common sense stuff, so we won't focus on it. Diagnosis, we use our DSM-5 criteria, so it's certain criteria that they pick and choose, and you need one of these, so depressed, mood, or apathy, and 4 of these at least. But don't remember that. They won't ever really ask you about that because that's not what we're focusing on second year. We're focusing on pharm in second year. So how do we manage it? We have all our non-pharmacological treatments first, so our physical activity, counseling, things like that, healthy diet, and then we have our pharmacological treatment. So we're going to increase the amount of monoamines in our at our receptors because that's really the problem with depression. So we'll talk about the neurochem and pathophysiology. So we've got this monoamine hypothesis, which says if you don't have many monoamines, so serotonin, noradrenaline, or dopamine, that's going to cause depression. And it's also linked to our monoamine receptor levels. So if we have less amounts of monoamine receptors, we're going to upregulate our actual amount of receptor levels, so they're almost more sensitive to the monoamines. If we've got more monoamine receptor levels, we're going to downregulate our monoamine receptor levels, so they're less sensitive. And that's just a homeostatic process that's going on. In depression, we've got an abnormal upregulation of this monoamine receptors, and that's going to cause our downregulation of the actual low monoamine neurotransmitter levels. So these are always correlated. That will always help you. So I recommend kind of committing that to memory. And so how are we going to treat our depression? Because we've got too many monoamine receptors, we can either decrease the amount of monoamine receptors we've got going on, or actually increase the monoamine neurotransmitters to indirectly decrease the amount of monoamine receptor levels in our body. And that's going to be how our drugs are working. So positive and negative effects in depression are kind of associated with specific receptors in general and specific monoamines. So our positive effects are mainly associated with noradrenaline. And so we get less of these positive effects in depression. So happiness, or like less of all the good stuff, basically. So bad mood, loss of happiness, loss of interest, loss of energy, and self-confidence and things like that. But we've also got our negative effects. So these are all the bad things, and we're getting more bad things in depression. So we're going to get increased negative effects, and that's going to be mainly due to serotonin. So we get guilt, fear, hostility, irritability, and depressed mood as well. So these are the drugs that we are going to be working on depression. So we've got TCAs, rest. We'll go through them one by one and try and focus on them in classes instead of actual individual drugs and what are the things that we need to focus on, because this is a long list of drugs. All right, so we'll start off with our TCAs. This is going to block reuptake of NORAD and serotonin. All TCAs have at least 2 of these side effects. So either going to block muscarinic receptors, histamine receptors of alpha-1 adrenal recepters. And these are all going to produce their own side effects. So muscarinic receptor blockade is going to produce that characteristic set of cholinergic sort of symptoms, so dry mouth, low vision, constipation, urinary retention, and delirium. Histamine receptors, you can imagine antihistamines, so antihistamines cause sedation as their side effect, or you can have our alpha-1 adrenal receptor blockers. So if you block the alpha-1 adrenal receptors in your smooth muscle, where they mostly are, you're going to cause vasodilation, you're going to get hypotension, and that's going to cause a reflex tachycardia because your heart's going to try to pump more to fill up that space, your intravascular space. That's why you get that reflex tachycardia in conjunction with it. All these don't really matter, but serotonin syndrome is pretty important. So if you give other antidepressants, you're going to get almost too much serotonin, and that's classified as a certain thing called serotonin syndrome. So you get agitation, confusion, sweating, fever, diarrhea, all these things. You probably won't need to identify serotonin syndrome exactly, but just know the word serotonin syndrome. Cool. So you got another TCA. This is mirtazapine or myosin. They are chemically in the same compound class, but they don't work as the same. They don't have the same mechanism of action. So they're going to block our alpha-2 adrenoreceptors instead of our serotonin mainly. The adverse effect is mainly going to be focused on our sedation and also that alpha-1 adrenoreceptor effect. Then we've got fluoxetine. So this is selective serotonin reuptake inhibitor. The name is what it is pretty much. It's going to selectively block reuptake of serotonin. So you're going to get more serotonin in that postsynaptic neuron. They're all associated with certain things, but this is mainly just for people who want to learn it. You don't need to learn that specifically. But again, you can get your serotonin syndrome if you have too much serotonin with other drugs. Venlafaxine, SNRI, so serotonin and noradrenaline reuptake inhibitor. Going to block uptake or reuptake of serotonin and NORAD. So same sort of does what it says. The name is what it does. It's going to be more specifically working on our serotonin. So it's again going to be causing serotonin syndrome, but it's going to have no effect or less effect on minimal effect on our muscarinic histamine and alpha-1 adrenoreceptors as opposed to our TCA, sorry. Moclobamide, so this is a MAO-A, reversible MAO-A inhibitor or REMA. MAO-A is going to be metabolizing on NORAD or serotonin. So if we block that enzyme, we're going to get more of that. Adverse effects you don't need to know. Tranylcypromine, blocking MAO, so that metabolic enzyme, but it's going to be an irreversible inhibitor. So while MAO REMA will wear off over very quickly, you'll need to probably take it every day. This is not going to wear off as quickly. It's going to need to take 2 to 3 weeks to wear off because you need to resynthesize a new enzyme pretty much. The main adverse effect, which I do commonly test, is the cheese reaction. So MAO-A also metabolizes tyramine, which is commonly in cheese products. And so it can cause this hypertensive sort of crisis. You get elevated blood pressure, you can get changes in your vision, you can get headaches as well, which are symptomatic of this hypertensive crisis. So that's really common to ask. So I would commit that to memory as well. Reboxetine does what it says what it does. So blocks reuptake of NORAD. Nifazodone, SARI. So not only is it going to block the reuptake of NORAD, it's going to actually antagonize the receptors, but it's going to also be used in anxiety as well. Side effects, probably severe liver damage, mainly focus on, but nothing else is that important. So a lot of different anxiety disorders also use antidepressants as well. This is just for your interest, but not that important. Bipolar disorder. So while depression is a unipolar disorder where your mood is only in one direction, bipolar is where your mood alternates between mania and depression. So like crazy, like where are the symptoms? Yeah, euphoria, grandiosity, all that kind of stuff, and depression sort of symptoms. How do we treat that? We give them lithium because we think that permeates their sodium channels, kind of blocks it and stops those channels from depolarizing, and that will stabilize their mood. But it's got a whole bunch of different side effects that are really, really bad. So you can get nephrogenic diabetes insipidus, you can get motor hyperactivity or nephritis or edema. So they're all pretty bad side effects that we don't really want to have. So it's a pretty toxic drug. But if you know that bipolar is treated with lithium, then you're probably good to go. OCD, it's what you think it is. So recurring obsessions and compulsions interfere with normal life and are time consuming. Pretty common. Yeah. Okay, schizophrenia. I think this is approaching the last one. So what is schizophrenia? It's mainly a psychiatric disorder characterized by disruption in thinking, language perception, sense of self, and it often includes the psychotic experiences, so either hallucinations or delusions. It's got a strong genetic component to it. So people with a family history are really much more likely to get it. And these are the genes involved. Wouldn't bother learning that. Pathophys. So it's mainly to do with your psychotic symptoms are mainly coming from an elevation in your dopamine. But there's also other things that are involved here. So activation of serotonin receptors or glutamate channel receptor overdose, blocker overdose. But mainly we'll be focusing on the elevation in dopamine that's going to be with schizophrenia. So there's a few different symptoms. We classify them again into positive, negative, or cognitive symptoms. So positive symptoms, you get your delusions. So people having abnormal ideas that aren't true, hallucinations, disordered speech, bizarre thought or thought disorders. Negative symptoms, so basically less of these things. So less socialization, less drive, less purpose, less emotions. And then your cognitive symptoms, so problems with their cognition. How do we manage it? 10 minutes left. Okay, yeah, we'll try get through very quickly. So we've got atypical antipsychotics and our typical. We use first line atypical and our typicals as second line. And we'll talk about. Yeah. Okay. So what's the neurochem? What's the pathophys? So dopamine is working in a few different pathways in our brain. It's working in mesolimbic. It's working nigrostriatal and tuberohypophyseal. So nigrostriatal is the one we associate with Parkinson's and movement. Tuberohypophyseal is associated with prolactin, so it's going from hypothalamus to pituitary. And mesolimbic / mesocortical is the one that's associated with schizophrenia. This is going from our ventral tegmental area down here in our midbrain brainstem kind of area, all the way up to our prefrontal cortex and nucleus accumbens, which is actually really important. We've got disruptions in this pathway. We're going to have too much dopamine in this pathway, and that's going to cause our schizophrenia pretty much. So how do we treat it? We use our potent agonist of dopamine receptors, and that's going to treat our symptoms. Yep, not that important. And how do we think about our adverse effects? The way we think about our adverse effects is we've got inhibition of dopamine in our other pathways. So if it's inhibiting dopamine in our tuberohypophyseal or nigrostriatal pathway. So we have dopamine antagonists in our nigrostriatal pathway. We're going to get things that are opposite to Parkinson's. We're going to have a drug-induced Parkinsonism. So we're going to have extrapyramidal side effects such as tremor, rigidity, all those trap symptoms that I was talking about before. We can have tuberohypophyseal pathway effects. So if we get dopamine agonists, we're going to have more prolactin, and we're going to get hyperprolactinemia. So that commonly manifests as gynecomastia and amenorrhea. Yeah, and this mainly happens when we have higher than 80% of D2 receptor blockage. That's also, that number was the same in Parkinson's disease. So if we get more than 80% blockage of receptors, we're going to get symptoms. Cool. These are other side effects that we have with antipsychotics. So again, our sedation associated with histamine, postural hypertension with our alpha-1 adrenal receptors, and then our muscarinic blockade symptoms, as well as some metabolic effects. So typical antipsychotics, they ask this a lot. So they treat our positive symptoms well, but not so much our negative symptoms. And the main ones are chlorpromazine and haloperidol. So they're both dopamine receptor antagonists, and they're going to have blockage of also those other receptors I was talking about. So they have a lower potency at dopamine receptors. So you're going to get less pyramidal side effects, so less Parkinsonism when compared to haloperidol, but you have more potency at your acetylcholine receptors. You're going to get more sedation and more orthostatic hypotension when compared to haloperidol. And that's probably the biggest two things that you really, really need to know about haloperidol and chlorpromazine. You also get these bunch of other side effects where you kind of guess these ones. They're just the tuberohypophyseal metabolic kind of side effects. You got haloperidol. Again, it's going to have that same mechanism of action, but it's going to have more extrapyramidal side effects. So chlorpromazine, less extrapyramidal side effects. Haloperidol, more extrapyramidal side effects, but it's going to have lower potency. So less sedation, less orthostatic hypertension. And this one's more so contraindicated in Parkinson's disease. So if people are having schizophrenia and they've got Parkinson's disease, you don't give them haloperidol at all, because it's going to worsen their Parkinson's disease because it's much worse at exacerbating those extrapyramidal side effects. The rest of these are the same as I was talking about before. This is a table to highlight that. So whereas chlorpromazine is plus plus for your dopamine, haloperidol is plus plus plus, so much worse. Cool. Atypical antipsychotics. So these are going to work in two different pathways. So remember, I was talking about prefrontal cortex and nucleus accumbens. So we'll talk about nucleus accumbens first. So this is our positive symptoms coming from too much dopamine working in the nucleus accumbens. Our negative symptoms are mainly going to be coming from hypoactivation of our prefrontal cortex. So dopamine works in our prefrontal cortex. If we have not enough dopamine, our prefrontal cortex is going to be not being stimulated as much, and that's going to lead to our negative symptoms. Serotonin comes in here, and it works by inhibiting these receptors. So if we've got more serotonin release, we're going to have more inhibition of this dopamine neuron. So we're going to have less prefrontal cortex stimulation. That's why we need to block the amount of serotonin being released here in order to actually increase the amount of dopamine that's going on in this prefrontal cortex. And so that's what these atypical antipsychotics are doing. They're working in both of these pathways. So we've got risperidone, it's going to do that thing. It's going to be a dopamine receptor antagonist in that prefrontal cortex, and it's going to be a 5-HT2 antagonist in that nucleus accumbens, and it's going to lead to inhibition of both negative and positive symptoms. We're going to get similar side effects. Yeah, you can just imagine if they're working in our other pathways as well. Olanzapine, same thing, but it's got more metabolic side effects and weight gain, hyperglycemia, dyslipidemia, all really, really bad. And it's much better for extrapyramidal side effects. So you almost get little to no extrapyramidal side effects. Clozapine, same thing, exactly same thing. So you can put all these drugs together. They all have the exact same mechanism of actions. And this is a really strong drug. It's for people who have refractory or resistant schizophrenia, or people who develop extrapyramidal side effects, because you get little to no extrapyramidal side effects. And the main one that you need to know about is fatal agranulocytosis. So they don't have enough white cells, so they are very immunosuppressed, more likely to get infections and die from it. So that's probably the big one, why we don't use it as much as the other ones, why it's kind of a last line kind of thing. Quetiapine, same thing, same side effects. Aripiprazole, not core, but it's a partial thing at both of them. So it's going to have less strength at both of them, but it's going to have less side effects as well because it's not as strong. Again, this table highlights all of that. In reality, these side effects are much less, much lower than all of these in actual like clinical reality. But this is the table Richard uses, so do whatever he says. These are some questions. So someone yell out the answer. Put it in the chat or whatever you want to do. You can PM, just so I know people kind of know what's going on. People awake? All right, so this one's going to produce our strong pyramidal side effects. So the answer is C, because remember, haloperidol is stronger at those extrapyramidal side effects, but less so the hypertension, less sedation. That's chlorpromazine. Then we've got patients being treated for depression, blah, blah. Oh, I can't actually see because of the thing at the top. But yeah, so people are saying B, good. So it's a monooxidase MAO inhibitor, which is good. Yes, good job. I'm glad you're all listening. That's mainly going to be associated with that cheese reaction. First line drug for absence seizures, so petit mal seizures, what do we reckon? Yep, so people are saying C, which is really good. I'm glad people are listening. Yay. Ethosuximide is used for our absence seizures. Carbamazepine mainly for our partial seizures, and like valproate pretty much for everything else. Good. And then I can't actually read the questions. I can't remember them. But which of the following statements is correct about levodopa for Parkinson's patients? So what do we reckon? Is it A, B, C, D, or E? So people are getting a couple different answers here. So it's not a MAO-B inhibitor because it's basically just it's a precursor to dopamine. It's not going to be a dopamine antagonist. It's going to be inhibited by peripheral DDC, which is correct. It's not going to, it does have a short half-life, but it's not 3 to 4 hours, it's 2 hours. And it doesn't act by stimulating tyrosine hydroxylase. The answer is C. And I think that's the end of my slides. So good job. Hope you all do well. Thanks for listening. And good luck for your exams. Any questions?
It's all good.
Cool.
Cheers, Kevin.
No worries. Finished on the